gap non-union is rare type of problem which have to face uh, nowadays more commonly because uh, for our daily practice in an emergency basis, at emergency we used to get multiple road traffic accident, and they used to suffer from bone loss. And due to this bone loss, for upper limb it can be managed by shortening, because in upper limb there is no issue of limb length discrepancy as such. But for lower limb, which is the most commonly affected bone during road traffic accident, bone loss will be very difficult to manage, and it has multiple consequences and problem, because in our living body mm, there is a tendency to fill the gap by soft tissue. Now, when you are dealing any case of bone loss more than 2 to 3 centimeter, that gap cannot be managed by acute docking. As a result, and if you manage it by acute docking, there is a chance of limb length discrepancy, because for lower limb at maximum 0.5 centimeter shortening can accept it, but more than that can be managed, but it is very difficult for that patient for doing his normal daily activity, and it need multiple operation, and it needs multiple hospital staying, it needs multiple operation complications. So the gap in the bone have to manage a very particular uh, protocol based way, and like this cubes, if you try to solve this cube without knowing the formula or how to reduce this cube in a particular manner, even for a whole day is not sufficient to make it out. Okay, see, before going in details in gap non-union, I already teach you about the non-union in our early classes. Now I just want to give you a overview of non-union classification. Dor Palais has been classified the non-union in two categories mainly: type 1, type A, and type B. In type A non-union, he uttered that the gap is less than 1 centimeter. So this is not our concern now, because it has been we have taken class over this non-union. But this part where his gap is more than 1 centimeter, he has broadly classified this in B1, B2, and B3. What this is classification? See, for lower limb, where two bone, especially in case of leg and in case of both bone forearm, where two bone presents, there are three type of non-union. Even for femur also, just see, uh, like if there is any bone gap but no shortening is present, this is called B1. Now there is a gap and along with non-union, but there will shortening, but there is alignment is normal, no deformity is there. And last but not the least, gap is there, bone defect is there, non-union is due to non-union there is some shortening with and some deformity also. So as the grading going on, the complexity going on. Okay, so now there are many technique to manage this. See, this is the weight bearing bone, tibia. Now the fellow bone is fibula. It has no weight bearing property. God is gifted this fibula and iliac crest for a huge purpose, because we can use this fibula in many operation. I already teach you about that. Now, by helping of this fibula support, there is a interosseous membrane here. Now, if we can put bone graft through this lateral aspect and we can lift a layer from the interosseous membrane and put the bone graft over here, it can cause a solid union. So the weight can transmitted through this and this. This is called Harman central bone grafting procedure, and it can cause iatrogenic synostosis of the proximal tibia fibula and distal tibia fibula. I will take class on synostosis next day, but just use synostosis special type of bony fusion where both bone is present, and in both bone there is a special movement, but there is some congenital synostosis and there is some iatrogenic synostosis. I will discuss it in my next class, but here for your concept, synostosis means the joining of the two bone, and we can do it iatrogenically by bone graft. So it can give a solid union. Is called central bone grafting or posterolateral bone grafting. It's called a Harman procedure. But believe me, this procedure is very complicated and outcome is not so good, and so just know the name. Now, another is Huntington procedure, used to done in child. What is Huntington procedure? See, due to any infection, there is a gap or atrophic type of non-union in the tibia. Now, due to this bone loss and the atrophic gap, after debridement, we will get this type this huge bone loss here. Now, how we manage? We can manage it by tibialization of fibula. This is a special type of operation done specially in the child because it has a maximum remodeling capacity. Now, we using this fibula as a fellow bone, we just want to fuse it proximally and fuse it distally. So by a screw or some fixation method, and we can cut this fibula here. We can shift this fibula towards the medial aspect, and same thing is distally. See, both fibula proximal and distally fixed with the screw. Now we put this patient with a slab and non-weight bearing. After that, when there is sign of a small union, we can allow this partial weight bearing, and due to weight bearing, that fibula will fused and it will get hypertrophied because this portion is with its normal blood supply and its soft tissue coverage, so it will act like a vascularized fibula. And this operation should not take huge time because no need of any microvascular surgery, just cutting the bone and shifting this bone towards this centralization of the this leg bone, and it can cause fusion, and in the long run it will get hypertrophied and it will help for maintaining this gap. Now, for this procedure, you can easily understand this is a very long procedure, isn't it? Very long procedure, and but in case of children especially, bone is so good, and it chance of high remodeling, that is a very popular operation, and outcome is quite good if it has been done with a expert hand. Okay, so it is also called Huntington procedure. Huntington procedure, proximal and distally fusion. And there is a special type of operation is called nickel grafting. I forget to write the name. It is called nickel grafting, NICOLLE, nickel grafting. What is this? In case of both bone forearm, if there is any type of non-union, suppose we have using a plate over there, it is got loose enough, and or any type of infection, we have lost a special portion of the more than 5 centimeter bone loss in the radius, or in case of Allah maybe. In that case, what will be problem? Suppose one bone has get the length, so another bone cannot be reduced. This If it is humerus, it can easily reduce and docking, and we can do a face plate. But here we cannot reduce this, because the length is gained by the another bone. So this type of one-sided gap non-union, how we manage? We can manage it by a tricortical bone gap taken from the iliac crest, and we will put this bone graft over here like a bridging effect, and we can artificially done a medullary cavity through a drill bit over this tricortical bone graft and put it, and we should not put any screw over here. We will just a long bridge plate, and we will give compression over here, and this bone graft will stuck in this area by compression. And before doing this, we have to maintain the normal ulnar variance. What do you mean by ulnar variance? For our wrist normal function, the tip of the styloid will be 1.5 centimeter distal from the ulnar styloid. This is the normal variance. This is called negative ulnar variance. This is very helpful for normal wrist function. Now, if there is any shortening, then that can cause DRG problem. DRG, distal radial ulnar joint problem, and is very painful condition. Patient cannot do anything on this hand. So if we put this in a bone graft and a plate, it can easily unite. This is called nickel bone grafting. This is a highly effective if it done in with a expert hand with a good care. This is called nickel tricortical bone grafting technique, mainly used in the both bone forearm. Up to 8 centimeter can up to 5 to 7 centimeter can be done, or more than 5 to 7 centimeter can be done by fibular graft also. Okay, so, but more than 8 centimeter fibular graft needs vascularized fibular graft. Then you have to call the plastic surgeon for microvascular anastomosis. But generally the bone loss is less than 5 centimeter. It can be easily managed by iliac crest bone grafting by centralizing or recolonizing the bone graft by drill bit, and put this over the gap and the bridge mode plating. Okay. Now for lower limb, where bone loss is more than 5 centimeter, what we can do? I already take class on muscular technique. I already take class on Iliarov, but I don't use this term bone transport. It maybe came as a short note, and you have to know about something about bone transport. What do you mean by this? It is special type of callostosis, or it is one type of destruction osteogenesis, or it also called membranous ossification, artificial membranous ossification by destruction. Now if there is a gap, we cannot docking this fracture site after debindment, and we can do a corticotomy here, subperiosteal corticotomy, that helps to maintain the blood supply over here. We can made a artificial fracture over here, but this proximal fragment and distal fragment is fixed with a ring fixator. Now what happened after doing this artificial fracture, after waiting 10 to 14 days, we can distract these three circular ring downwards, and by distracting this we can gain the length, and here this middle fragment will come gradually downwards to uh, for docking with this lower part. Okay, so this is called bone transport. Okay, but you have to give time for solidifying this callostosis part, and there is a issue regarding long term ring fixator problem and long term non weight bearing, and there is also a issue when I already told you, if there is any gap, you must understand that for getting this gap there must be some insult over the skin and soft tissue, and this lower one third is very notorious for bad scar and non-union. So the soft tissue coverage here is very bad and fibrous tissue is inevitable. Now where surrounding tissue is not healthy, then how we expect this gap will be clear for bone transport? That must be filled up by fibrous tissue. But in the long run, if this gap is very big, then again there is a chance of non-union here due to interposition of the uh, emerging soft tissue or migrating soft tissue in between. Now this is an issue. For this bone transport has been can be faster by another corticotomy in lower end. Okay, this is called trifocal bone transport. Now you can confuse with this term. If there is any gap, we can do debridement, we can do acute docking, and we can do pressure. This is called unifocal bone transport. If this gap is more than 3 centimeter, then we have to go for proximal corticotomy. So we can have a acute docking here, we have to do a proximal corticotomy for the limb lengthening. This is called bifocal bone transport. Now if we do another corticotomy here, we need a faster docking of this gap, and so it will take half time than this, so chance of soft tissue interposition is less. So this is called trifocal bone transport. But believe me, this procedure is so lengthy and so complicated, and it will need a highly trained institutional support along with a learning curve. Learning curve means for beginners this operation, to perform this operation perfectly is very difficult. So but you have to know all the terms: unifocal bone transport, bifocal bone transport, and trifocal bone transport. In unifocal there will be no corticotomy. For bifocal there will be a compression along with this corticotomy, and for trifocal there will be two corticotomy along with this transport of the bone. Okay. Now new update of Iliarov. Iliarov is a ring fixator. We can put the ring all around the limb. Now same principle is applied by external fixator, but this external fixator has been changed, and the speciality of this, there is a shank screw which is taper shank screw. Means this shank screw we take this bone purchase very hard. I have already teach you regarding the radial loading of this screw. The radial loading of taper shank screw is very high than a normal shank screw. It can hold this bone very firmly, so it helps for bone transport from only one direction. No need to put ring fixator here. So this is called orthofix. Okay, and it has a multiple angulation option. We can manage any deformity also. Now there is also some modification. This is called LRS, limb reconstruction system. Here same principle is done by using orthopedic spin, but here there is a railroad technique. Here we cannot manage any angular deformity. We can manage the linear discrepancy, and the railroad is very tough than this orthofix, and but it needs a special expertization on this operation. Otherwise, the result of this operation will very bad. And keep in mind, the soft tissue healing and proper debridement is the key of the success of this type of operation. Just know the name. This is called limb reconstruction system, and this frame is very lightweight because of presence of carbon fiber. Okay. And a special update for Iliarov is modified Taylor frame. What do you mean by modified Taylor frame? It has a 6 telescopic rod present in crisscross manner over this Iliarov ring. In this this telescopic rod has a special inbuilt microprocessor sensor over there, and it has been programmed by a special type of software, and this can be manage any type of angular deformity, any type of shortening, any type of problem. Before putting this special type of frame, we have to take a special CT scan of that patient, and this 3D CT scan have to put as a data to this software, and this software has will calculate the cora. What do you mean by cora? Cora is the correction of the center of the rotation of the osteotomy. Means suppose you are dealing with a angular deformity. Now you will do a osteotomy. Osteotomy means you will cut a bone and you will do the correction. Now from where you will use this cut, and how you reduce this angulation by maintaining a special point of rotation. This is called cora, and this cora is a very special point which is very subjective. Now man to man variation will occur, and as we are all human, we must do some mistakes, but for human body, this this center of the rotation, if we miss at least 1 millimeter, it can cause 10-degree problem in the long run. So this measuring the cora, center of rotation of the axis, is very difficult, and very difficult to execute also. But this software has a inbuilt property. They can assess the deformity, and they can automatically assess the cora. Means where you have to put the osteotomy, and how they will progressively reduce the deformity. Okay, and for 3D plane they will assess all type of deformity, and this has been programmed previously by Iliarov principle 25 that will change any type of deformity with a acceptable range is 1 millimeter for whole day. They will not increase the range, but they are already programmed by according to this software. They can easily manage this deformity without touching the frame. Once you have put this implant, and you have already put this software, this rod automatically reduce it itself. But in Iliarov we have to reduce it in mechanically we have to change this length of this rod, or you have to change distract it annually. And that is actually, this is a artificial intelligence. Okay, this mechanical job is replaced by this software, and this software is already put in this telescopic rod by a microprocessor. Okay, can you get it? Just remember, this is a special type of frame which can itself do the deformity correction according to the need of the patient deformity, and this is patient specific. Okay, so yeah, this is the latest update of this Iliaro, and I think I can over this special and extraordinary topic is called gap non-union. So I think I can solve this cube. Thank you.